All right, sounds great. So good afternoon, everyone. I'm Elizabeth Heald, board chair and co-founder of Kawasaki Disease Canada, and I'm so excited today to continue our information and sharing series, The Heart of the Matter, on today of all days. Before we get started, I'd like to share a few housekeeping items. So the platform today, as you can see, is a Zoom meeting rather than a webinar. What that means is you can see us and we can see you. And we ask that you ensure you just remain on mute to avoid disruption of our scheduled presentation. And I'm loving the little guy on the top right of my screen. So we will have a question and answer period at the end. But if you do have a question during the chat or during the presentation, we ask that you submit it through the chat function, and I'll try to keep an eye on it during the presentation. If we don't get an opportunity to answer all of your questions, we will send out an email later on. You will see that this event is being recorded and it'll be available on our YouTube channel, and we'll let you know when that is available. We at Kawasaki Disease Canada are so grateful for the many families across Canada and around the globe who help support our efforts in so many ways. We are also grateful for the many healthcare professionals that help us carry out our mission towards enhanced awareness, education, support, and research to help find a cause. Like the pandemic, Kawasaki disease knows no boundaries. We have a common enemy and we have a common aim. We are stronger together. We are so very pleased that you could join us today. So I am delighted to welcome Dr. Brian McCrindle. Dr. McCrindle is a staff cardiologist, section head of Preventive Cardiology, a senior scientist at the Hospital for Sick Children, and a professor of pediatrics at University of Toronto. For more than 25 years, he has been caring for patients with Kawasaki disease, contributing research and guiding policy. He has been the co-chair of the International Kawasaki Disease Symposium and was the lead author for the American Heart Association Kawasaki Disease Guidelines. We are so very thrilled that Dr. McCrindle provides direct support to Kawasaki Disease Canada by sitting on our advisory council. As I mentioned, Dr. McCrindle chairs the International Kawasaki Disease Registry, and he's the principal investigator with the NIH Pediatric Heart Network, for which one of the studies is currently determining cardiac outcomes for children who have had the multi-system inflammatory syndrome associated with the SARS-CoV-2 infection, or as you might know it as MIS-C. Today, Dr. McCrindle's focus is on SickKids and Beyond, and provides recent insights from the Hospital for Sick Children in Toronto and the International KD Registry in the era of COVID-19. Without further ado, Dr. McCrindle, over to you. Thank you.
Okay, thank you for the introduction. So I'm just going to pull up my slides. So I'm going to be talking about Canada's role in Kawasaki disease, and I have the following disclosures. So you may know that Kawasaki disease was first described by Professor Kawasaki in 1967. And we know that Kawasaki disease is an acute disease that strikes young children. But when Dr. Kawasaki first described Kawasaki disease, he did not know that it was associated with cardiac complications. That only came up later as he was following up some of these early patients. Kawasaki disease now has been reported worldwide and has replaced rheumatic heart disease as the most common acquired heart disease in children in developed countries. So I'm going to be weaving through this, what Canada has contributed to our knowledge of the field of Kawasaki disease. But I'm going to first go through some of the history of Kawasaki disease in Canada and how frequently it occurs in Canada. The first report of Kawasaki disease in Canada was published in 1980 by Dr. Otto Teixeira from the Children's Hospital of Eastern Ontario in Ottawa, where he reported 7 cases that had been accumulated in the Ottawa area between 1976 and 1978. Subsequent to this, in 1985, some investigators at SickKids, Dr. Richard Rowe and Dr. Vera Rose, surveyed 15 sites in Canada and reported on 357 patients. And I have to say I'm indebted to these two for establishing the presence of Kawasaki disease in Canada. And in fact, the reason why I came to Toronto in the first place was because Dr. Vera Rose was retiring, and she happened to be the cardiologist who followed all the Kawasaki disease patients at SickKids. So I started off in Kawasaki disease, not because I had a specific interest in Kawasaki disease, but because I inherited a huge practice of Kawasaki disease patients from Dr. Rose. We then started, once I took over the population, I started tracking numbers of cases and characteristics of cases. And we published our first work in the year 2000, where we were actually surveying all of the hospitals in Ontario and asking them to fill out case report forms every 3 years. And at that time, from 1995 to 97, our systematic surveillance revealed that the incidence in Ontario was 14.5 cases per 100,000 children less than 5 years of age. We kept up that systematic surveillance, timing it with the International Kawasaki disease meetings every 3 to 4 years, and again published in 2010 the results of 4 of these systematic surveillances, and had noted that the incidence of Kawasaki disease had risen over time to now 26.2. Now, the unique thing about Canada is that we have a universal healthcare system, and therefore some medical information is collected on the entire Canadian population. And that gives us a unique advantage over other countries where their healthcare systems are a mix of private and public, or predominantly private systems, and there's no universal data collection. So we started looking at using some of this administrative data from the government to see if we could determine the incidence of Kawasaki disease without having to survey every single hospital in Ontario. And we published a paper in 2018 that showed that if we just use the administrative data, it overestimated the incidence by about 7%, but was fairly consistent. And in that recent period of time, we noted that the incidence may have gone down slightly at 19.6, but was stable. There were significant regional and seasonal variations, and about 3.5% of the patients were noted to have aneurysms. The advantage of using the administrative data is not only now did we have information just in Ontario, but completely across Canada, except for Quebec, which reports into a separate system. At the recent International Kawasaki disease meeting, we reported an update of the epidemiology in Canada, again using the administrative data, but up to 2017, and adjusting our rates on the basis that we knew that the administrative data overestimated the number of cases by 7%. And so our pooled annual incidence across Canada was 22.7 per 100,000 children less than 5 years of age, again with the usual male predominance. One of the things that we did note with these data is that the seasonality of Kawasaki disease did not affect all age groups equally, in that the youngest age groups tended to be more affected by the seasonality of Kawasaki disease, which I can tell you right now, here in Ontario, we're in the peak of that seasonal incidence, which usually occurs sort of in January, February, and sometimes into March. We tracked the incidence over time and noticed that it was pretty stable for the youngest patients with more variation for older patients. And then we also were able to look at a cross-Canada map of Kawasaki disease with the darker blue color indicating a higher incidence. And you can see that the highest incidence in Canada occurs in Nova Scotia. I'm not exactly sure why, but in Ontario and in British Columbia. So using some of this administrative data, plus also linking it with surveys that we did ourselves, our own systematic surveillances, and incorporating environmental data, we tried to build on an observation that had suggested that wind patterns over China were responsible for some of the variations in the incidence of Kawasaki disease in Japan. So we thought that was an interesting observation. And so we tried to link this to environmental factors that might be at work in Canada and perhaps even globally. And we published 2 papers on this, and this has sort of changed our thinking about how Kawasaki disease happens and caused us to create this model whereby you have an underlying predisposition for immune issues, either due to genetic modifiers, genetic genes that are active, or an immature and developing immune system, which might explain the age and the race predisposition for Kawasaki disease. The immune system is then modulated by environmental exposures, things like environmental pollution, pets in the home, proximity to a body of water or trees or pollen. If you had a high exposure, that would lead to a high tolerance should you encounter the trigger to Kawasaki disease, and therefore you'd have a normal response. But for those who were predisposed but lived in relatively protected environments, when they came across that trigger, had a delayed and exaggerated immune response that gets manifested as Kawasaki disease. Now, we think that the trigger could be a number of different things. There's probably no one specific trigger, but it could be an infection. It could be something in the environment. It could be an allergen. It's possible that it could be all of those things. And that's one of the issues that has been impeding us from discovering the etiology or cause of Kawasaki disease, because it may be many things that cause Kawasaki disease. And as we now think, SARS-CoV-2 infection, coronavirus, may be one additional trigger. So this allowed us to create a model by which we could take these factors and determine an individual's risk for developing Kawasaki disease, but also we could guess what the incidence of Kawasaki disease might be within a given country. And when we looked at this, we created a model where we looked at the proportion of the population of East Asian descent, your position in the world in proximity to Northeast China, the proportion of the population that lived in urban settings, and then the concentration of fine particulate matter air pollution. And those 4 factors lumped together could give us a model that could pretty much confidently predict what the incidence of Kawasaki disease might be in a given region in the world. So I think that tells you that we are, in Canada, looking at our own personal situation, have made some important contributions into understanding the cause and how Kawasaki disease comes to happen in a population. We've also looked in Canada and contributed to many aspects related to Kawasaki disease itself, both its diagnosis and its treatment. We were one of the participants, while Canada was not participant in the original IVIG trials that were primarily conducted through the US. Toronto was a member of the Pediatric Heart Network since it first started in 2001, and participated and were a high enroller site for one of the first trials the network undertook, which was a clinical trial of steroids in addition to gamma globulin, to try and prevent coronary artery abnormalities. Unfortunately, a single dose of steroids proved not to have any effect on coronary artery outcomes, but subsequent trials, primarily in Japan, have shown that if you target a high-risk subsegment of the population with a longer and higher dose course of steroids, you may have some impact on preventing coronary abnormalities. We've also done some work in comparing the outcomes of patients who have incomplete versus complete criteria for Kawasaki disease, and have shown that the factors that predict someone's susceptibility to being resistant to treatment or to develop coronary artery complications are the same, regardless of whether you had all the clinical criteria or not. We've done a number of investigations of specific laboratory abnormalities. Perhaps the one that we looked at the most has been serum albumin, which, if it becomes very low in the acute disease, can be a significant marker of risk for coronary artery complications. We've done a number of different studies that have looked at patients who do not respond to the initial dose of IVIG. And we've helped to clarify definitions of what it means to be resistant to IVIG, and also what might be the optimal second or third line treatment to try and prevent coronary artery complications. We've had access at SickKids to a number of different brands of IVIG. I've noted significant differences in terms of their effectiveness. We've also noted, done some significant work that's unique worldwide, and showed that sometimes exposure to IVIG in susceptible patients can lead to breakdown of red blood cells and lead to anemia. We've done a number of work in collaboration with investigators in the Netherlands to look at the mechanism by which this happens. And perhaps the one leading person who does more basic science research in Canada related to the etiology of Kawasaki disease is Dr. Ray Young at SickKids, who's one of the rheumatologists who has a particular interest in the immunology and genetics of Kawasaki disease, and has now embarked on some interesting work during the COVID pandemic. But the big contribution of Canada, and in particular the Hospital for Sick Children and perhaps Saint-Justine Hospital in Montreal, has been in the realm of cardiology. The first thing, we've made major contributions into specifying how coronary artery complications should be defined, how we can determine based on those coronary complications what the future might lie for the patient and what outcomes they might be at risk for, strategies to prevent clots forming in aneurysms, the role of lipid-lowering medications like statins, and then more recently, novel ways to assess the heart and the coronary arteries, which I'm going to be talking about. So one of the first papers that linked outcomes to the size of the coronary arteries after the acute disease was published in 1992 by Teiji Akaji while he was working here at SickKids, and showed that those patients who had the largest aneurysms measuring 8 millimeters or greater had complete persistence, while the smaller aneurysms were more likely to decrease in size and to decrease much more quickly. Now, the problem with this is that aneurysms were being defined by their raw measurement. And we know that the patients in Kawasaki disease come in a number of different shapes and sizes. And what a 4 millimeter coronary artery in a teenager may be completely normal, in a 6-month-old, that may indicate a moderate to large aneurysm. So we need to kind of adjust these measurements to the size of the patient. And one thing we can do is calculate something called a Z-score. So a z-score is the number of standard deviations in a normal bell-shaped population for a measurement for a patient at a given age and gender, how far away you are from that normal measurement in terms of the number, what we call standard deviations. So 95% of the population, more than 95% of the population will lie within 2 standard deviations, either above or below. You can imagine that patients with giant coronary artery aneurysms have z-scores or standard deviations that are far in excess of more than just +2. And indeed, when we looked at this and came up with a classification system that was based solely on z-scores, it actually looked pretty reasonable in comparison with the absolute measurements. And we defined aneurysms based on the z-score range, with larger giant aneurysms having z-scores of 10 or greater. So now we could look at how aneurysms evolved over time, but evolved over time in relationship to the size of a growing patient. And we were able to look at how our classification system actually lined up with someone's risk for clinical outcomes. And what you can see is that the clinical outcomes, meaning thrombosis in an aneurysm or a myocardial infarction or a heart attack, really only occurred for those patients who had coronary artery z-scores at some point that were 10 or more. So one of the things we were always interested in is a number of centers. Kawasaki disease is rare, and aneurysms are a rare subset of a rare population. So if we want to look at how patients were faring with aneurysms, we would have to pool information across multiple hospitals and multiple sites, which led us to the initiation of the International Kawasaki Disease Registry, which started in 2013. Our first paper was published in 2020 and involved 1,651 aneurysm patients, which was an unheard of number of patients to be pooled together from previous reports. We noted there were no heart complications in those who had z-scores that were less than 10 maximally, and that the aneurysm size decreased significantly and became normal, mainly in those that had small or medium aneurysms, but was possible still for some patients with large aneurysms. And that patients who had z-scores less than 10 seemed to be at no risk after 10 years of any kind of cardiac event. However, if your z-score was above 10, you had a 20% risk of developing a stenosis, 18% risk of a thrombosis or a clot, and 14% having a major adverse cardiovascular event. And I'm just going to show some of these curves that show in the patients with giant aneurysms their time to develop these very events. I want you to pay attention to the graph on the right, which shows the risk of developing a clot. And you can see it goes up very quickly in the first weeks or months after developing Kawasaki disease, and then sort of levels off a little bit, but never gets down to a flat line. One of the other things we noted is that patients with z-scores above 10 or larger giant aneurysms were not all the same, and that some giant aneurysms were more giant than others. And indeed, the more giant your aneurysm was, the greater the likelihood you were going to develop both a stenosis, but also a thrombosis as well. Particularly if the Z-score got to be above 40, about 50% of those patients, before they even reached a year of age, had already had a thrombosis or a clot. These are the graphs for myocardial infarction and other adverse cardiac events. This is the percent who required a revascularization, usually with bypass surgery. But the number who actually went on to require a heart transplant was exceedingly low, extremely rare. So I mentioned that we've also made significant contributions with defining the best way to prevent clots. And this was one of our first papers published in 2010, where we compared for patients who had severe aneurysms and required blood thinning, we compared the use of enoxaparin or low molecular weight heparin versus warfarin, or also known as Coumadin, and noted that the use of heparin was just as safe and effective as using the warfarin, with perhaps a greater ease in keeping the level of anticoagulation stable with the heparin than with the warfarin, and perhaps that the patients who were initially treated with heparin had a greater likelihood of their aneurysms decreasing over time. We've further looked at this within the context of the International Kawasaki Disease Registry, and have shown certainly that for those with giant aneurysms, that those patients who received some anticoagulation definitely did a lot better than those patients who did not receive anticoagulation, with the majority of those clots happening very early on in the course of the patient's illness. And one of the most common errors that gets made in the management of someone with acute Kawasaki disease who is evolving or getting aneurysms is that you need to anticipate that these aneurysms are going to get bigger, and to start the anticoagulation in anticipation of that happening, not waiting for it to happen and then initiating the anticoagulation, by which time the patient may already have a clot. We noted that some patients required a combination therapy, either with aspirin, together with either warfarin or heparin, but also sometimes with an additional agent called Plavix as well. And that there's always a concern about bleeding risk as you increase the amount of blood thinning that you try to pursue. And we noticed that the bleeding risk was actually quite low regardless of the combination that was used. Within the context of the IKDR, we looked at whether current treatment for long-term management of patients with aneurysms matched up with the guidelines. And the answer was, yeah, it largely did, given that there's some wording in the guidelines that gives you some discretion as to, and wiggle room as to how you want to manage specifically an individual patient. We also know that there's a number of new agents that are coming down that have received some study but have not yet gone into clinical practice in the Kawasaki disease world, which may bypass some of the problems that we have with warfarin. And you know, I led a clinical trial of rivaroxaban, unfortunately, that did not include any Kawasaki patients. But as part of the Pediatric Heart Network, SickKids participated in a clinical trial of apixaban, for which about 30 to 40% of the patients enrolled were Kawasaki disease patients. The results of that study are just being analyzed right now. So one of the things that, since I also run the clinic at SickKids for kids with high cholesterol, I have a specific interest in lipid-lowering medications. And indeed, if you had an adult patient who had the same level of coronary artery problems that a Kawasaki patient has, automatically those adult patients would be put on a high dose of what's called a statin. Now, what I questioned was, given that I was used to treating cholesterol problems with statins in kids, and I had all these Kawasaki patients, what if I proposed that we use some statins and see how they worked in patients with Kawasaki disease? given that statins do much more than just lower your cholesterol, they have a number of additional effects that make them anti-thrombotic and anti-inflammatory, which may have specific benefits to patients recovering from coronary artery complications due to Kawasaki disease. So I mentioned this to Ray Young, that I was interested in statins, and she said, well, why don't we test it out? She had a mouse model for Kawasaki disease. And so we tested it out, and sure enough, the statin impeded a number of the adverse immune responses that led to vascular damage in this mouse model. However, it was achieved at doses of a statin that you can give to a mouse that you just can't give to a human being, which sort of stopped us from thinking about using it as an acute therapy, but allowed us to continue to think about it in terms of a chronic therapy. We further looked at the safety of using a statin. Since these kids have normal cholesterol levels, is it going to be as safe? And particularly also because the kids are younger than the usual lipid patient, and showed that it was as safe and effective in very young kids with Kawasaki disease as it was in adults. And I know that Dr. Jane Burns in San Diego has been interested in studying statins as acute therapy, but the results are yet unknown. So moving on to novel assessments. So Canada has contributed to novel ways of looking at the coronary artery damage in Kawasaki disease patients through a number of specific novel technologies. One way we can look at the coronary arteries, one thing we are always wondering about in the coronary arteries is we can measure the inside dimension, but we have very little information as to the actual wall of the coronary artery. And we know that over time, the walls in the coronary arteries of patients with aneurysms greatly thicken, which can predispose them to developing stenoses. How do we see the wall? Well, here's one way, is we can use a catheter-based technique called optical coherence tomography. And this was first reported in the Kawasaki population in Canada by Kevin Harris in Vancouver, and then was picked up by Najib Dada and his group at San Justine Hospital. And this is a picture of what you might get with what's called OCT. With a normal coronary, you can see on the left, but the coronary on the right is within a coronary artery aneurysm, and you can see a great deal of thickening of the wall that's sort of asymmetric around the wall. And that might be valuable information for us when we're trying to think of somebody's long-term prognosis. I've done some work with Dr. Dada and Mitchell Benovoy, looking at how we can use coronary angiograms to assess the distensibility or stiffness of the coronary arteries following Kawasaki disease, because you could imagine as these coronary arteries get thickened, as you see on the OCT, that they become quite stiff as well. Through some work that was actually funded a bit through KD Canada to Matthew, we collaborated with a group in Stanford through the Allison Marsden lab to look at computational flow modeling of blood flow through the coronary arteries, looking for abnormalities in flow that might suggest a risk for thrombosis. And this is one of the diagrams from the original paper that shows, the areas in blue are the areas of the greatest flow disturbance. And if they're circled in red, they also correspond to sites where we know thrombosis developed clinically. So that's an important thing that we hope is going to get some airplay once the technology gets sort of standardized and becomes much more user-friendly, such that right now to come up with those simulations takes a week of intensive work, which we can't afford for every single patient. But if we can automate some of that, it may actually bring this into as information that we can use to treat our patients. Another way Canada has contributed to the field of Kawasaki disease is by looking at preventive cardiology, which is my thing, and whether kids who have Kawasaki disease are at increased risk for the usual atherosclerotic or hardening of the arteries process. And then we've also had a very strong interest as a group in looking at psychosocial outcomes for kids who've had Kawasaki disease. So in terms of preventive cardiology, we've done a number of different studies, some of which have included some measures that you can make using ultrasound of either the thickness or the stiffness of the arteries. And have, in general, suggested that there are very few differences between normal kids with regards, and Kawasaki patients with regards to standard things like cholesterol levels, blood pressure, etc. And that these may translate, however, into an increased stiffness and thickness of arteries besides the coronary arteries, but that this is also heavily correlated with what the coronaries are looking like. We've also did a study where we used wearable devices to look at physical activity levels in patients who've had Kawasaki disease, and definitely determined that they were much lower than in the general population, which suggests that the Kawasaki patients should be both monitored for traditional risk factors for heart disease, but also be strongly encouraged to follow a healthy lifestyle. So Nita Chahal, who is the nurse practitioner who is my partner in the Kawasaki disease world, is very interested in psychosocial outcomes in the Kawasaki disease population. And she's probably one of the leading researchers in the world in this area. I don't think there's hardly anybody else that are looking at these kinds of issues. And it began, when we noted, here's some comments from one of her first papers, that parents were frustrated by the lack of information available in the lay language and the limited scientific knowledge regarding the long-term consequences of this disease. However, the parents of children with coronary artery complications expressed persistent anxiety even years after the acute phase of the illness due to the uncertainty of the long-term prognosis. So it was these two things, the uncertainty about the long-term prognosis, that prompted us to get into the International Kawasaki Disease Registry and pool aneurysm patients together to look at these long-term outcomes, but also this persistent anxiety and the frustration and the information needs that led Nita Chahal to pursue further work. In the most recent work she presented at the International Kawasaki Disease Symposium, which was a qualitative study looking at what educational and psychosocial needs might be desired and applicable for patients and for both parents and adolescents who've had Kawasaki disease and coronary artery aneurysm. So we're hoping that a greater understanding of the factors and the needs will lead to effective interventions that we can use to promote well-being and healthy psychosocial outcomes. So a lot of this work I was able to incorporate into the American Heart Association Kawasaki disease guidelines, which was really, it was 5 years worth of work. and was published in 2017. And so these were the first guidelines that actually addressed things in terms of Z-scores, that actually calibrated how you would manage a patient related to their level of coronary artery involvement, and had a strong focus on preventive cardiology, but also psychosocial outcomes, and an entire section on the importance of ensuring seamless transition from pediatric to adult care. So this last little bit, I'm going to move on to what's gone on with COVID. So you know that children early on in the pandemic were relatively spared in that if they got COVID, they were either asymptomatic or developed very limited symptoms. But then starting around in March of 2020, there were reports of this inflammatory syndrome that seemed to be a delayed response to having had an acute COVID infection. And that had a lot of overlap with clinical features of Kawasaki disease. And I published a editorial to this effect in the Journal of the American Medical Association, together with my former research project manager, Cedric Manlio, that suggested that perhaps this MIS-C, or inflammatory syndrome, shared a lot of features and perhaps were the same disease as Kawasaki disease. This finding of MIS-C led us to be involved in two things. One through the Pediatric Heart Network, which started what's called the MUSIC study, that created a large series of these patients over a 2-year period of time. But for me, it actually also caused me to shift the International Kawasaki Disease Registry to start collecting information about these MIS-C patients at the same time that we were collecting acute Kawasaki disease patients. So we presented this recently at the International Kawasaki Disease Symposium and divided up our patients, which included MIS-C and Kawasaki disease patients, according to what their COVID status was. And they fell into 4 groups: positive, possible, negative, and unknown. And the majority of the patients who had an unknown status were from early in the pandemic, where we didn't really have widespread COVID testing. So what you can see is that as you go from positive down to unknown, the number of KD features that the patient has increases significantly. And it's likely that the patients with negative COVID status or unknown are more likely traditional Kawasaki disease patients, whereas the positive and possible are more likely the MIS-C patients. And this was true when we actually looked at whether they met the diagnostic criteria for either incomplete or complete Kawasaki disease. We noted that patients who were positive or possible for COVID were more likely to have abdominal pain, diarrhea, or vomiting, gastrointestinal symptoms at presentation, and they had more severe clinical presentations, with a greater proportion of them requiring presenting in shock or requiring intensive care unit management. The coronary arteries were a lot larger in the patients who had negative or unknown Kawasaki disease, unknown COVID status, probably reflective that they were more the true Kawasaki disease patients. And this is true when we group these patients according to Z-score into aneurysm categories, that the patients with negative or unknown, more likely to be KD, were more likely to have aneurysms and have larger aneurysms. So we continue to work with the International Kawasaki Disease Registry. I think we have close to 2,000 patients. Now we're closing the data set and hope to be analyzing some data within the next couple of months to be able to present abstracts to the American Heart Association meeting. but we continue our work with the Pediatric Heart Network. But in summary, I think this discourse, and I'm sure I left a lot of important Canadian work out or missed it. I think it shows that Canada actually is a world leader when it comes to Kawasaki disease, particularly outside of Japan. So thank you, and I think we can now entertain some questions.
Wow, I can just say, I mean, I think we keep up to date a little bit with the research that's going on, but when you see it like that, Dr. McCrindle, it's just quite amazing. We have some questions coming in through the chat, and then I'm going to ask any participants that want to turn their camera on and their mute off to ask live. They're more than welcome to do so. But in the meantime, I think maybe the first question will go to Dr. McCrindle is, how does someone obtain their Z-score or Z-score?
Yeah, so the Z-scores actually should be part of every report you get when you get an echocardiogram. So they should be reporting both the absolute measurement and then the Z-score. So the Z-score, you can't have the Z-score unless you actually measure the height and the weight of the patient at the time that the echo was obtained, because those are important factors into calculating the Z-scores, but they should be part of the reports.
Okay, excellent. So if someone, so this is from Melissa, who's a KD survivor, born in 1983, and at age 5 was diagnosed with KD. So perhaps, you know, the medical records may or may not show that.
No.
She should, no, probably not at that point.
Yeah, so back then, they may not have even actually given you a measurement of the coronary artery. They may just have qualitatively said, oh yeah, that looks big, or that looks like an aneurysm. So, you know, the farther back you go, the foggier the pictures get, and the less information that was put into a report.
So is there any recommendation then for Melissa if she's wanting to know, you know, how she stands? Is that just try to see, I'm assuming, Melissa, and you can chime in here if you'd like, but I'm assuming she's not currently followed by a cardiologist. Is that right, Melissa?
Hi, everyone. Yes, thank you. I am not currently seeing a cardiologist or anything to that effect. I did have some EKG work done probably in 2012, but it was heart palpitations just due to stress and anxiety of life, and no other real information was shared with me at that time.
Yeah, so one of the one thing that crops up is patients who during the acute illness either had no coronary involvement or had some dilatation that resolved quickly within a few weeks. We know that those patients, from our long-term data, particularly from the IKDR, are at risk for nothing in the long term. So they have no risk of any long-term cardiac complications. And so it used to be, when I first started at SickKids, that we would at least follow those patients for a year. But after, you know, several years of doing normal echocardiograms in those patients at 1 year, we decided to eliminate that. And so now patients who've had no problems or transient dilation that went away very quickly, we actually discharge them and do not see them anymore. So I'm not sure if that, Melissa, if that's the category you might have fallen into.
I believe so. I do know that my illness was diagnosed very early and no lasting impacts were noted. And I did do, I believe, just the aspirin for a year with lots of monitoring within that year. But since then, again, yeah, just wondering, you know, now that I'm later in life, what I should be talking to my practitioner about on this topic.
Yeah, so I actually tell my patients when I discharge them that there's no need for any for the future or ongoing cardiology assessments. But I do remind them that having had Kawasaki disease is now just part of the patient's medical history. And if someone ever asked, did you have any illnesses as a child, you can say, yes, I had Kawasaki disease, and but I had no heart complications whatsoever and was discharged. And that should be where it ends. However, what I always recommend is that if you've had a history of Kawasaki disease, that just means perhaps you should be a bit more careful about, risk factors for heart disease and a healthy lifestyle.
Great. Okay. Great information. Thank you very much.
Thank you, Dr. McCrindle and Melissa. Melissa also asked a question, Dr. McCrindle, that we have heard before, and it's with regards to vaccines, not the COVID vaccine, but in this case, Melissa is saying about having polio and the polio, diphtheria, and tetanus. And is there any research that you are aware of that studies vaccines against gene mutations such as ITPKC gene?
Yeah, so no, I'm not aware of any vaccine information and genetics, but I can tell you that Kawasaki patients, the only restrictions about vaccination for them is that after the acute illness, as you've got the gamma globulin, if you were treated with gamma globulin, you've got it circulating around your system, that those antibodies may neutralize a vaccination before it has a chance to stimulate an immune response that would be protective. So it really mainly applies to live virus vaccines like polio. And it's why when we discharge someone, we say, you should put off getting vaccinated for 11 months, because that's when people feel that the gamma globulin is out of the system. That doesn't mean that getting vaccinated before that 11 months is not safe. It's completely safe. It's just that you may not get the immune response, the protective immune response. And if you do happen to, if like a disease is running around in the population and you want your child to be protected, go ahead and get the vaccine, but the patient may need to have a booster sooner rather than later. And then with regards to anything in the adult world, I haven't heard of any association with vaccines and Kawasaki disease, except as misinformation.
Right. Okay. Thank you. There's a new question that's come in from Shannon. She says, my grandson was diagnosed with Kawasaki disease 5 months ago, and in the last month has been COVID positive. What are his risks for heart issues now, and where can I find more research and information on pediatric KD cases with COVID?
Yeah, complications related to first of all, complications in the pediatric age group related to COVID are incredibly rare. And Kawasaki disease is incredibly rare. So to kind of research the intersection of two incredibly rare problems is next to impossible. That being said, there are groups like the IKDR, and also there are lots of governmental agencies that have been monitoring COVID and COVID-related complications, that if there is some sort of signal that is of concern, it comes up very quickly, and then it gets further investigated. I've not heard of any of Kawasaki disease patients being of any greater risk for either developing COVID, developing complications related to COVID, and certainly developing any complications related to vaccination for COVID.
Okay, thank you, Dr. McCrindle. And on that same note then, And I know that you, given the conversations we've had in the past, you wouldn't be able to specifically comment on this, given that you don't know the nature of the child, but this is from Lauren. My daughter had her first COVID vaccine on December 1st and was diagnosed with KD December 22nd and treated with IVIG. Should she receive her second vaccine now that she has recovered?
Yes. So Kawasaki disease is not a reason to delay. It doesn't make you more risk for developing complications related to vaccination. And so there's no real reason why you should delay. However, in one of the things that's being reported in Canada that they couldn't do in the States, in the United States, they had virtually unlimited access to vaccine, and hence they were able to follow a vaccination schedule rather strictly. Here in Canada, we had problems with procuring vaccine, and so there was a period where we decided to delay the interval between the first and the second dose so that we could get more people to have their first dose and at least have some coverage. And looking back on that and comparing it to data that comes out of the States, it appears that delay may actually have prevented some complications, some of the incredibly rare complications associated with COVID vaccination. So I wouldn't be concerned. I think you're okay to go ahead and get vaccinated, but don't be concerned if you feel that needs to be a delay. I wouldn't delay it more than 90 days though.
Thank you.
Thanks so much. Okay, does anyone have a last question they would like to ask? Karen, I see you've come. Karen Lynn, come off. Cam, would you like to ask a question?
Yeah, sorry, I'm masked right now. I'm actually at SickKids, so I have my mask on. Actually, I had a quick question, Dr. McCrindle. I know when you're talking about the information you guys are gathering with the IKDR, with the MIS-C patients, as well as Kawasaki patients, I was curious is there any data being gathered with that, with the MIS-C patients, if they have a previous history of Kawasaki disease? Is that one of the data points that's being gathered?
Yeah, so I'm not sure if it's in the IKDR, but I think it might be in the music study. The music study is only enrolling MIS-C patients. I'm not sure that they've got, I think they've got close to 2,000 patients now. They've closed it to further enrollment. But I'm not aware of any patient who, if they had a previous episode of Kawasaki disease, it was completely coincidental with an episode of MIS-C. Just because two things happen together doesn't necessarily mean that they're causally related. That you have to rule out whether it's just a coincidence. That's why it took a while for us to figure out whether vaccines were actually a rare cause of heart inflammation, because we had to figure out whether this was just a coincidence or whether it was causally related.
Right. So, okay. I was just curious because I thought, I know, sorry, go ahead.
Yeah. So whenever you're trying to look for an association between two very, very rare things, it becomes exceedingly difficult.
Understood. I just know that that's the question that was on a lot of people's mind, especially at the very, very beginning. Yeah. And MIS-C was just emerging. I just thought it'd be an interesting data point, because if you actually came up with, let's say, 0, then that would give parents, even if it's not actually grounded in enough data point, would give parents a little bit of relief that we probably aren't at risk for experiencing MIS-C, just solely based on our Kawasaki disease previous episode. So that's why I thought it was an interesting thing. I didn't know if that was information that was being collected.
Well, I can tell you, if there's a case of that, it gets passed around quickly by word of mouth within these connected groups, and I haven't really heard anything.
Okay, good to know. Thank you.
Dr. McCrindle, do you have time for one more question? I see we're just a minute over time. Karen Lee, you have a question?
Hi, doctor. Just out of curiosity, the IKDR criteria, including kids, I think my understanding is that you're including children who do not have any aneurysms at this point, I guess post-COVID, or in the COVID era, but prior to COVID, you were not including that sample population. Can you talk about that a little bit?
Yeah, so prior to 2020, January 2020, we were really only collecting aneurysm patients. And because we're primarily a cardiology group, and that's the group of patients that we were interested in. It lines up with the reason why we started the registry in the first place. It's only after Miss C started getting reported that we decided to change our data collection. And so as of January 2020, we started collecting acute Kawasaki disease patients, regardless of what their coronaries look like, together with Miss C patients, and then together with any patient who had an acute COVID infection who happened to have a cardiology assessment. So I can tell you the number of those acute COVID patients is next to zero. So the registry is really a combination of Miss C and Kawasaki disease patients. We're not sure how long we're going to keep this acute data collection going, probably for, we know, at least another 6 months, because it's very labor intensive. We may have enough answers and enough patients. And at that point, we'll stop collecting the acute KD patients and we'll go back to start updating everything about the aneurysm patients.
Thank you.
Great, thank you so much. So it is time to close now. If you do have any future questions, please feel free to submit them via one of the methods that you connect with us. But a huge thank you to you, Dr. McCrindle. We are thankful for your collaboration with Kawasaki Disease Canada, your support of our mission, and we are so grateful that you inherited Dr. Rose's roster of patients all those years ago, and that you have made so many contributions over the last, I guess, 25 years to Kawasaki disease research. And before we close, a huge thank you to all of you that have logged in, as well as all of those that I know that will be watching after the fact on our YouTube channel. Your keen interest and support broadens the effectiveness of our collective efforts. Please stay tuned for details on our social media platforms of future sessions in our The Heart of the Matter series. Thank you, everyone. Have a wonderful day and stay safe. Thanks again, Dr. McCrindle.